In 6 minutes, we are reading a JAMA study on AI-powered scribes in clinician workflow. The article is by Rotenstein, Holmgren, Fombley, and colleagues, published in JAMA in 2026. PMID 419205565. DOI 10.1001/JAMA.2026.2253. This is a research explainer, not clinical or policy advice. Picture a busy restaurant kitchen at dinner rush. The clinician is the chef. The electronic health record is the order board, prep log, receipt printer, and closing paperwork all at once. An AI scribe is like an assistant taking notes while the chef cooks. This paper does not claim the assistant fixes the whole kitchen. It checks the time ledger across 5 large kitchens, less documentation time, slightly more visits, and whether late-night paperwork still remains. Stay to the end, because the most useful part is knowing both what the evidence supports and what it cannot prove. The research question is simple: after a health system gives clinicians access to an AI-powered scribe, do EHR time, documentation time, after-hours EHR work, and weekly visit volume change differently than they do among clinicians who did not adopt the tool? The background matters because the EHR is not just a typing box. It carries documentation, messages, results, billing, and coordination work. Prior research treats EHR time and clerical burden as important parts of clinician workload. AI scribes are appealing because they promise to remove some of that documentation burden. This was not a randomized trial. It was a multi-site longitudinal cohort study. The team used real-world rollout data from 5 U.S. academic healthcare institutions between June 2023 and August 2025, then estimated relative changes using a difference in differences design. The study included 8,581 ambulatory clinicians. Of those, 1,809 were AI scribe adopters. The sample included attending physicians, advanced practice clinicians, and resident physicians across primary care, medical specialties, and surgical specialties. Importantly, the study measured workflow, not patient outcomes. The exposure was receiving access to an AI scribe. It was not guaranteed high-intensity use. At 4 of the 5 sites, eligible physicians generally opted in. That matters, because clinicians who choose the tool may differ from those who do not choose it. The outcomes were 4 practical workflow measures: total EHR time per 8 scheduled patient hours, documentation time, EHR work outside scheduled hours or on unscheduled days, and weekly ambulatory visit volume. In other words, time burden and clinical capacity were both on the table. The basic idea of difference in differences is to compare changes over time in adopters with changes over time in non-adopters. The models included clinician fixed effects and time fixed effects, and the authors examined whether pre-adoption trends were reasonably parallel. That strengthens the design, but it still is not randomization. The main result, AI scribe adoption, was associated with 13.4 fewer minutes of total EHR time and 16.0 fewer minutes of documentation time per 8 scheduled patient hours. Weekly visit volume was about 0.49 visits higher. Helpful direction: modest size, not a dramatic transformation. One result is especially important: after-hours or unscheduled EHR time did not change significantly in the primary analysis. So the tool seems more clearly linked to documentation time than to eliminating all late-night EHR work. Subgroup findings suggested larger changes for primary care clinicians, advanced practice clinicians, female clinicians, and clinicians who used the AI scribe in at least half of visits. These patterns are interesting, but subgroup results can reflect workflow, use intensity, and implementation differences. The authors also ran robustness checks, including event study displays, excluding individual sites, excluding some samples, and using an alternative difference in differences estimator. The broad direction was similar, so the message does not rest on one single model. Here is the overread warning. This paper does not prove that AI scribes improve patient care, solve burnout, or should be adopted everywhere. It estimates associations and workflow measures under specific real-world implementation conditions. The limitations are substantial. This was observational, not randomized. Adopters and non-adopters may differ in unmeasured ways. Implementation and vendors varied across sites. Follow-up was limited. The study did not directly measure burnout, patient safety, or care quality. When reading a digital health paper like this, ask 4 questions first. How is the tool defined? Who could use it? Are the outcomes workflow metrics or patient outcomes? Does the design handle before-after changes and group differences? These questions beat a headline every time. Here is the recap. First, AI scribe adoption was associated with less documentation and total EHR time. Second, the effect was modest, and after-hours EHR work did not clearly fall. Third, this is useful evidence about AI implementation, not a universal conclusion. For the full service guide and contact routing, visit www.enentutor.com. For free statistics concepts, software demos, and paper analysis lessons, visit YouTube at ENentutor. For case examples, short knowledge posts, upcoming talks, and service updates, follow ENentutor on Facebook. The safe takeaway is this: AI scribes may save some workflow time, but local decisions still need human review of cost, quality, privacy, training, and implementation fit.